Please do not put your call on hold. And if you're on WebEx, you can hit the *6 or highlight your name and hit the mute button. And if you have a question, you can raise your hand using the little icon. Lastly, our sessions are recorded and will be posted on the Community Clinic Voice website for future playback. So I'd like to just take a quick roll call to see who's with us today. We have our presenter today. We have our SPA 3 presenter, Becky. We have Kern.
Hello.
Hi. We have Fresno HCAP, UCSF, San Francisco. We have our evaluation team, Lisa and Maggie. Christina Wildlake, our Kaiser funder from the north. Sherry Bathurst from Kaiser also. Sonia Shaw, our grant manager from Southern California. Vicki Barakat. Vicki, I'm sorry, who are you representing?
I'm with Pomona Valley Hospital Medical Center with SPA 3.
Welcome, Vicki.
Thank you.
Is there anyone else on the line who is just on our telephone line that I've missed? Great. So thank you all. Thank you all for being with us today. We appreciate you taking the time and your interest in today's program. So as I said, today we're going to be discussing integrating care coordination, and our guest highlighted speaker today is a Southern California coalition. East Valley Community Health Center is the lead agency, and the coalition is SPA 3, Specialty Care Planning Coalition, led by Becky Ketchlick. Hi, Becky.
Hello, Louisa.
Thank you for being with us today.
Thank you for having me.
Great. As you remember, those of you who were on the line last month, care coordination is one of those clusters that has been defined and approached in many different ways. As you remember, last month we had a presentation by our Westside Venice Coalition here in Southern California by Nancy Rodriguez. And she has a very large group of care coordinators who have various tasks and responsibilities. And one of the big roles that their care coordinators play in their surgery days that they've coordinated with Kaiser is that they follow the patient from the first moment they get the referral down to when they come back to the medical home. So they really make sure that the patient has all the documents, has all the tests that they're needed, make sure that they get transportation or if they need translation services, and really follows them and holds their hand throughout the process. Whereas other teams may not have that detailed a role in terms of their care coordination, they may just merely be somebody that tracks the referral through the system and may not have that much interaction with the patient. So there's a lot of variation from one end of the spectrum to the other. So today Becky is going to be sharing her particular approach in her coalition and what is different or what is exciting or challenging. So without further ado, let's talk with Becky. So Becky, why don't you tell us, briefly describe what is the process that led your coalition in SPA 3 to focus on developing a colorectal cancer screening program to increase access to specialty care, because this is a very unique program and a very important one. So tell us a little bit about what led that process.
Yeah, certainly. Well, first I just want to say we have done so much work around the planning, just like the other coalitions with their own strategies, and we are just so excited with our work and happy to be here on this call sharing our triumphs and also sharing our challenges. We initially in the planning process conducted an internal needs assessment. So we gathered data from our participating clinics. We also conducted several focus groups in different languages. Our goal was to identify barriers and challenges to obtaining specialty care perceived by the uninsured and underinsured patients of our clinics, of our participating clinics. So once we gathered all the necessary data, our coalition, the Specialty Care Coalition, collectively engaged in a process to narrow down the scope of specialty care priorities. And basically what we did is we had a criteria for selecting strategies and criteria for deselecting strategies or specialty care areas. I'll go through the rationale for selecting first, and then I'll briefly talk about how we went through the deselection process. In no means was this in a priority order, but we had 7 criteria. The first one was selecting an area of specialty care that had a high demand. 2, prioritizing specialty cares in terms of the ability to be able to make an impact in the community and to be able to measure those outcomes, those health outcomes. Ability to be able to improve quality of care, 4, determine an area of specialty care in which demand could be decreased, and 5, conversely, in which we could increase access as well. We also wanted to select a specialty care area in which we were able to reduce overall cost. And last but not least, the coalition wanted to ensure that the area to be selected was achievable in terms of the work and last but not least, sustainable. That was extremely important to us to be able to sustain the strategy on a long-term basis. Our criteria for deselecting areas of specialty care were low referral rate, an acceptable wait time, a general consensus from our coalition that specialty care area would be just too difficult to implement and difficult to address, especially for one of the first specialty care programs that we were going to be implementing. And also if there was any specialty care area that the SPA 3 group, special health planning group, was already addressing. So once we had our criteria, our strategies, the top 4 were dermatology, gastroenterology, podiatry, and endocrinology. We took that information back to the medical directors, and I'd have to say that hands down, the 2 that were selected were dermatology and gastroenterology. Right now, currently, we're very deep into the gastroenterology. We will also be doing a dermatology program, but that's we're still planning it. How we're measuring success, we are measuring it in the sense that we are able to ensure that the participating clinics in our coalition are able to adopt the screening strategy. We switch modalities from the GUAIAC FOBT to the FIT or IFOBT. And we are screening patients ages 15 to 79. We're also measuring success and our ability to be able to educate patients and the importance of screening. Continue the work tracking and improving provider and patient compliance. Being able to coordinate the referrals for them and support the patient through the referral process for diagnostic colonoscopies. And these are just descriptives, but we've developed metrics to be able to quantitate that as well. Now, in terms of the role of LAC USC Medical Services in the program, we are referring our patients who are at high risk colorectal cancer. And the patients that have a positive screen, once they go through the IFOBT screening, we're referring those patients to LAC USC for diagnostic colonoscopies. Until recently, the relationship that we had with LAC USC was just through the RPS system. There has not really been communication with them, but I'm proud to say that last week we were able to meet with representatives of LAC USC. We met with Dr. Kemp, Raymond Kemp. He's the medical director of the Ambulatory Care Center, and we also had an opportunity to meet with Dr. Lauren Lane, GI liver specialist, and we had the opportunity to meet with key staff members in the IT department and the referral center. The goal of our meeting was to create program awareness, express the Specialty Care Coalition's desire to work together and improve communication, and of course fast-track our patients referred to this program. As a result of our meeting, I should say that wait time for diagnostic colonoscopies is about 5 months. Because of the lack of capacity right now, they're unable to expedite the process from there. But we did develop a connection between our physician champion and someone in the head of the referral center, where if there is a problem on a case-by-case in terms of being able to expedite the patient, then we have a contact person that we're able to pick up the phone and call and say, this patient really needs to go in much quicker than what we're being told that we have to wait. So that's good. The other portion is that part of the program, we need to be able to measure the impact of the program in terms of are we making a difference to our patients? Are we saving lives? And we need results, diagnostic colonoscopy results, to be able to measure that. And right now, we are not able to obtain that from the county. So there was a willingness from LAC USC to implement a process through their system whereby we would be able to open up a file that gives us the patient results. So I believe that our meeting was quite successful.
Great, Becky. It looks like you're making progress. Are there any questions for Becky regarding the program that she's described, or comments?
This is Sherry Bathurst. I'm with Kaiser Permanente here at the Downey Medical Center.
Hi, Sherry.
And I have a question. Hi there, friends. Thank you for your time. You mentioned the term fast-tracking your patients. And does that simply mean that you are just developing those relationships to be able to call on the phone and be able to try and fast-track them, or is there some actual process in place?
Yes, that's a very good question, Sherry. Well, we would like to see our patients treated much quicker than the 5 months. Currently, we're working with a private provider as well, where the patient has a copay, and the process is much quicker. We feel that 5 months is a little bit too long. So, especially if they're being sent, they're not being sent for a colonoscopy screen. They're being sent because the screen that we're using is showing that they're positive. So we feel that's important that our patients get quicker care.
So just so that I understand, the 5-month wait is not a wait for a colonoscopy, but rather a wait for treatment of an already diagnosed condition?
Correct. Of not a diagnosed condition, I wouldn't, but the screen. Because there are although the whole process of being able to change our screening modality is to be able to screen more accurately. The guaiac, as we found out through our research, has more false positives. So not to say that it's a for sure that they're positive for colorectal cancer, but we feel that we're doing a much better job in identifying those patients and in reducing the false positives. Does that make sense?
Yes, thank you.
Thank you.
Thank you, Sherry. Yes, just a comment. Because of capacity in LA County, the wait is really long for this type of specialty service. So they are really doing their best to build those relationships to try to develop a program and a process that will help identify and get these people through the process a little quicker than they now are. Great. Any other questions or comments?
This is Hal Yee at San Francisco General Hospital.
Yes, Dr. Yee. How are you?
Good. I had a comment and a question. The comment is that, I don't know that anybody should feel so terrible about a 5-month wait time in the setting of screening for colorectal cancer, given the very, very long natural history of polyps. I mean, obviously we want to do it as quickly as possible, but knowing what the demand is at LAUSC, I would guess that they have lots of procedures that have much more urgency. So I think it's just important as we think through these access issues that we consider what the natural history of the disease is that we're referring.
Mm-hmm.
The second thing is I'm just curious whether you have any sense yet of what the percentage of patients that you have who should get screened are getting screened, and what is your goal for the percentage of patients you hope to screen percentage-wise?
That's a really good question, and due to the time frame as to, right now, just to back it up a little bit, we have a 4% of patients that are coming up with positive IVOBT. We are in the midst of tracking those patients. It is something that is in our metrics, how many of those patients are actually going through with the diagnostic colonoscopies. The newness of the program has not, I don't have quite a firm number on that just yet.
Okay. No, it'll be interesting.
But yes, and I'm happy as we're gathering the data, as it's coming in, I would be more than happy to share that information with all of you.
So just to give you a sense, in San Francisco of
Mm-hmm.
our city clinics,
Mm-hmm.
there's quite a, let's say, a range. So if I am recalling correctly, at different clinics, the range of the proportion of patients who are screened is somewhere between about 25% all the way up to around 70%. So just so that you have a sense of maybe where you can be shooting for.
Uh-huh. Okay. Thank you. Thank you for that information.
Thank you, Dr. Yee. I think this will be a great resource as well for you, Becky.
Yes. Dr. Yee has been very helpful to us in the past in our planning process. So I'm happy to see that you're on the call.
So why don't you tell us, Becky, what role does care coordination play in your program, and where are they located, and what are their key responsibilities?
Sure. We have 6 participating clinics, and each one has a care coordinator. The time allotted to the program by the care coordinators is dependent on the size of the clinic. In other words, the care coordinators are not just dedicated to the program. Their roles primarily, I would say data tracking is the big one for us. Being able to track information on the screening with IFOBT, patient compliance, and also the colonoscopy referrals. They serve as patient navigators in terms of offering the patient, presenting the patients with the different choices. Currently, we have 2 options. We have, as I mentioned, a private colonoscopy provider in which the patient has a copay but has a shorter wait time than the average 5 months at the county. And so if the patient chooses the private provider, there's coordination in terms of paperwork and contact with the private provider, and providing patient education as well. And in addition to that, with the county, we're tracking the referral disposition completely from A to Z, and in other words, from the time that it gets entered into the RPS, time it goes into clinical review. We have it completely broken down, and that's part of it as well. Is we want to see the impact of the program in terms of results and follow-up for those patients.
What about training, Becky? Has there been any training for these coordinators? Can you talk a little bit about that?
Yes, we prior to beginning the program, we went through training in terms of what it is that we're trying to accomplish, and it was the training was a little bit overhead. We allowed each clinic to develop their own workflow. So in terms of workflow, that was internalized. Because of the complexity of our group, we have clinics that are larger, have an electronic medical record systems, and then we have smaller clinics that are, just on rudimentary, chart review. So the training was just more overhead than deep training, if you will.
I see. Any questions or comments regarding care coordination and the roles and responsibilities in this program? Okay, why don't you tell us what has been the most exciting accomplishment thus far, Becky, with your program? And then we can talk about some of the challenges and your key lessons learned so far.
Sure. I'll be happy to share that. I think being able to frame our agreements from our coalition, how we're going to develop this program, ensuring that the administration of it was framed. We created a program manual, which has been, I think, very helpful for the clinics, for the care coordinators as well, since they weren't in to listen to the ins and out of it, but they're able to refer to that and understand what we're trying to do, in the steps that we're taking administratively as well. Being able to switch our modality, I think that was huge for us. Having a consensus from 6 of 7 participating clinics to switch from the GUAIAC FOBT to the immunochemical FOBT, huge accomplishment. Coming together, the power of having a coalition, and having that coalition come together and negotiate rates with the laboratory vendors and also with the private provider that we're using to conduct our diagnostic colonoscopies. Those are huge accomplishments for us, as well as being able to engage Dr. Yoshinaka, who's the chief of GI over at Kaiser Permanente Baldwin Park. He has been helping us clinically and is going to be helping us in the future in convening meetings, yearly meetings with our medical directors to talk about the clinical aspects of the program.
Okay, and what have been some of your lessons learned and some of the challenges you've had to face and how you've overcome them so far?
Yes. Okay. One of the challenges and things that I maybe would be more aware of for the future would be that being aware that processes sometimes are slow. It took us program implementation for our group was back in July 2009, and it took some time, as I understand now that is natural. It took some time to get everybody on board. I think I cannot say enough about ensuring. I mentioned earlier that training was done, that the workflow for each clinic was not mandated. I think that the workflow is key for the care coordinators to be able to succeed in their work. And I think that if this any program is to be done in the future anywhere, be involved in that and ensure that there is a good workflow happening no matter what size the clinic is. I think those are key, and because of that, we've experienced challenges in ensuring timely and good quality data.
Okay, any questions or comments regarding some of these challenges? When you talk about workflow, can you tell us a bit more about that, what that entails?
Okay, yes, workflow, when I refer to that, is having a clear understanding as to how those patients will be identified at your clinic. What will happen, clearly understanding as to how will the kit, the screening kit, be provided? Will you follow up on those results, on those patients who have not returned the results? Is there going to be some follow-up to that? How are those patients going to be identified? How are they going to be called in? Are you going to call them? Are you going to send a postcard? Just the day-to-day work, the day-to-day protocol in being able to ensure that all of the key elements that are going to be tracked have some way of being tracked.
I see. Because that varies from clinic to clinic, as you mentioned.
Yes.
Right. Okay. Any comments or questions for Becky? All right. So tell us what's changed or improved. I think you've touched upon this with the implementation of the Specialty Care Initiative, and more specifically with the involvement of your specialty care coordinators.
What has changed? I would say that having the program has allowed us to just more formalize and be more consistent, systematic as to offering screening, and through that being able to improve both provider compliance and patient compliance, being able to measure the progress. I'd like to share that, as I mentioned, we have a 4% out of the patients that we have screened. We have identified 69 patients with the positive for colorectal cancer. We've referred through our tracking. We know that we've referred 23 patients to county and 25 patients to our private providers.
Great. Have you seen a difference in your no-show rates, Becky? No, I don't think I can comment on that yet because I don't have enough data to be able to. Okay. Any other questions or comments? So you've spoken a little bit about this already, but what would you recommend to your fellow colleagues working on or considering in their work plans the plan to go ahead and involve care coordinators or care coordination?
Yes. I mentioned the workflow, so I won't go through that, but another key aspect, I believe, is to ensure that the coordinators are identified early on in the process and to some capacity are included in the planning process. since they're going to be doing the legwork, I think that many times when we are creating a project, our view is we might have a bird's eye view, and sometimes you miss basic steps that are necessary that might be obvious to a care coordinator. I also think that it's very, very important, critical that there's buy-in on their end as well, and that they realize the value of their work and that they know that it's meaningful and making a difference to the patients.
Very good point. Any thoughts on that, Dr. Yee?
No, not really.
Okay. Very important point, because they're the people who are really tracking that patient through the system.
Mm-hmm.
So tell us, what are your next steps for integrating care coordination?
Yes, well, I want to be able to improve communication, and so my goal is to continue our efforts in building relationship among with and among the care coordinators, and we have plans for convening monthly conference calls. Because of our geographic spread, Spot 3 geographically is very spread out. It's difficult to do it in person, although that would have been my first choice. But we have plans for convening monthly meetings. And so we have a schedule developed for the rest of the year, and the goal for those calls is to provide an opportunity to learn from each other, provide communication, education updates on program-related issues, progress, whatnot, discuss challenges, and also celebrate successes. Also, prior to our calls, I think we will have opportunities to discuss what topics the coordinators would like to discuss. And also, I think that these calls would be a great forum for ongoing communication that will hopefully ensure good communication with the care coordinators and among them. And also be able to convey the care coordinator. Sometimes when you're doing things over and over, I think that maybe, frankly, you lose steam. And I think it's important to be able to convey to them that this is really good work. Share. If there's situations where we can share how their work has made a difference, be able to share that with them, and in the end, be able to continue getting good data from them. So those are our plans for the future.
Great. You mentioned telemedicine. Are you working on that as well? Will they be involved in that as well? Probably, yes. We're going to be doing a teledermatology program, and we're in the planning process. So we'll see. I think so. I think that it'll be with this program, we've learned a lot. So hopefully we'll be able to incorporate some care coordination with that. We'll see. Great. Now, Becky, is there any question that you would like to ask your coalition colleagues that are on the line today?
Yes. I guess my question would be, is there is a coalition out there that is doing work around care coordination? I'd like to know if there's something that you're planning doing differently. Was this helpful?
This is Hal. I just wanted to say that given that I do know a little bit about, the challenges in Los Angeles, I think this is really quite remarkable progress.
Thank you.
I mean,
Thank
it's
you,
a very challenging safety net.
Thank you. Thank you very much, Dr. Yee.
Thank you, Dr. Yee. Anyone else? Any other comments or questions for Becky? Well, thank you, Becky. You've done a great job of describing your program, and I agree. You sound like you've made some progress given all the challenges that you face in Los Angeles County with this particular area. If you would like to connect with Becky and email her any other questions or give her a call, you can do so at area code 909-964-3220, or her email is bkachlik@evhc.org. Are there any other final comments or questions for Becky or regarding future webinars? Well, thank you all very much for your participation today. I just want to remind you to fill out the survey, and we've ended a little early, so thank you again for being with us. And next week we will have our webinar that will focus on embedding guidelines into the referral process, and we'll be sending you more information on who our presenter will be and login information. Thank you again for being with us, and have a great afternoon.